Actually, male impotence or ED predates manifest coronary artery disease by 5 years. If you have this sort of a problem, you are very likely to have a coronary artery disease in a manifest form in another 5 years. It can come as a heart attack or angina.
Sir, what exactly is the difference between a regular DM cardiology and an interventional cardiologist?
Now, once you are a cardiologist, you are just certified as a doctor who has seen enough of cardiac disease and can do simple procedures and actually can diagnose, but you are not a specialist. So, interventional training in India after doing your DM or DMT.
Or what should a cardiologist aim for in his CV?
The institution from which a person has come, the publication and the type of publications, and the type of people under whom he has been mentored.
Sir, what is one trait that you look for in a cardiologist when you are training with him?
Never dying attitude is they would have the perseverance, they will have the thing that they would work their guts out to actually achieve it.
I noticed there were a lot of publications on AI in cardiology.
In the next 15 years, we see everything is going to be AI based. It is still going to that stage.
How many cigarettes are too many? Some people say we just smoke one or two.
You just can't advise anybody to smoke. Even one puff is bad. To take aspirin and smoke? No. Absolute no.
Hello everyone, welcome to DelliDocs. Our today's guest is none other than Dr. Professor Eminent Khanna, the Chief Interventional Cardiologist from Apollo, Delhi. He's not just an interventional cardiologist, he has been and is the president of multiple societies, cardiology societies in India, Asia Pacific and international societies. He has trained a lot of cardiologists under him. He has numerous publications, I think more than 150. And he has talked today about a variety of topics ranging from cardiac health, of course, then training cardiologists, how he does the procedures, what's his psychology behind them, what are the ethics of practice, the research is involved. And I think the most interesting part was when he talked how AI is changing the cardiology today. And he has in fact got more than 40 publications out of it and has a lot of advices to share how to do the researches. And guys, please, you have to watch it till the end because there is a gift waiting for you. And to get the gift, you have to comment or send us emails. Let's quickly jump into this podcast. Thank you, Professor Eminent Khanna, sir. Thank you for coming.
Thank you for calling me, Dr. Naman.
Sir, you have done more than 35,000 angioplasties. You have pioneered a lot of global firsts. Was there a defining moment in your life when you thought that this is why I do what I do?
Okay, so let me answer this in two things. When I grew up and I wanted to join medical profession, I actually wanted to be a cardiac surgeon. That was my dream and no other branch. But then I had high myopia and then so I in fact did my house job also to start with in surgery. But my brother became a cardiac surgeon. My father was the first cardiac surgeon of the country. So then I thought of joining medicine and interventional cardiology because that was the branch which was the in thing. So that was one defining moment how I got into interventional cardiology.
Sir, which year are we talking about?
This is 1988, 87, 88.
Okay.
And then, I was looking around who should be my mentor after I did my DM and I sort of moved around in the country and I thought the best person then would be Dr. Seth in Scott Heart Institute. And that's how I joined him and I got trained by him. So he's my mentor and he's actually trained me to what I am today. And then we were doing interventions. Scott's used to be one of the pioneering centers in whole of Southeast Asia. In fact, that was the time when angioplasty actually got introduced in the country and the stents came in. And so we have seen the entire era of, right from balloon angioplasties and there were dissections and we had to call surgeons for emergency surgery. Then the stents came in and then, we were certified to do stents and it was such a big relief that you don't have to call the surgeon in the middle of the night. Many a times when you had dissection and the patient were, collapsing, we had to do perfusion balloons and sit for hours together to tack up the dissection without surgery and to avoid surgery. So we have seen the entire gamut, what were the complications of angioplasty and how the interventional cardiology, especially in coronary disease, has evolved. So those were the real good times for us to actually understand the nature and the progress of intervention. So our thought process is very different from what the new generation sees in interventional cardiology. Today, it's more of a quick fix, but we have seen it evolve, so we know the thought process behind every, hardware behind every intervention and what are the possible complications. And, the best thing was, this thing was coming in and Escort used to give us a very free hand, and we have mentors like Dr. Trayan and Dr. Seth who used to really give a free hand and there was so much of a thought process and teaching, and there was time for teaching and understanding things that for hours we were together doing it, and almost every day the cath lab would finish after midnight. So that used to be our driving force, and nothing was more interesting to us and did not give us kick. Apart from doing interventions, managing complications, and doing something very new for the first time, presenting cases. And that was the way it was in Escort Heart Institute. I don't think any other institute or any other center in the world where such a driven cohort or a group of interventional cardiologists and surgeons were there, because we were the best. We were getting the newest technologies. We are mastering them. And you won't believe that was the time when most of the new intervention and techniques and devices were actually in India. We were the first users, and they used to come to US and get FDA approval much later. So in fact, after a few years, we were the people who actually trained the world on newer interventions. So that was one time which was like a golden era of interventional cardiology.
How big was your team?
There was one team of interventional cardiology which was headed by Dr. Seth, and there were many more very good senior people like Dr. Trayan, Dr. Bandari, and then many more. And all of us then trained under these mentors, and actually the team grew to almost 20 to 22 people. Wow. And almost every interventional cardiologist or, DM, a fresh DM or a cardiologist who wanted to do intervention actually came to Escorts for training, short-term, long-term observation. And we were one of the centers which actually established interventional cardiology and interest in interventional cardiology at that time. So, I've seen those eras, and the whole department was being set up by Dr. Seth and his team, and it was a real fun. Everybody, we spent less time in the house, even when our kids were very small. Our house, our place of work was all Escorts.
It's no work-life balance for you.
That time there was no house and no. It was only work. Work was the biggest pleasure, and newer technologies and mastering them, that was the biggest thing which gave us the thrill to work. So I won't say that was the best thing.
Right.
And if I go back and analyze the whole thing, I think there should be a work-life balance, but that's what all of us sacrificed. But actually that brought us to where we are today.
Absolutely. So till when were you in Escorts?
So Escorts, I joined in 1995, and I was there up till 2005 before I joined Apollo.
Okay.
So for 10 years I worked there, and we had such a wonderful team and such wonderful mentors like Dr. Seth and Dr. Trayan, who would get the best technologies, be interested in developing the center and teaching and getting everything in that center.
Right. Sir, you talked about seeing angioplasty evolve over the years. Sir, initially and compared to today, what is the time duration that has changed? For example, how long does it take for an angioplasty today, and how long did it take back then?
So that's very interesting. I remember during the initial days of angioplasty, when stents were not available, sometimes an angioplasty would take 2, 3, 4 hours to do, because if there was a dissection and artery was closing, the only way to actually save the patient and to go ahead was to put a balloon, and it was a perfusion balloon, and keep auto perfusing the artery and wait for half an hour, then again see whether there is a collapse of the artery or not. If it was there, then do it again. So sometimes it used to be many hours, and eventually then you had to call a surgeon, and if it didn't work out, then there was an emergency surgery. So doing an angioplasty and you would wait till the surgery is over. It used to be sometimes overnight you would do an angioplasty in rare cases, but normally it would have been few hours in some cases, and if there was no complication, it was pretty fast in few, say 15-20 minutes. But we were not doing very complex procedures, and then a lot of things came in. The biggest relief was when the stent came in. Of course, they were not medicated stents. They were just simple stent which could actually prevent the artery from collapsing.
Metallic stents,
balloon expandable, and that actually brought down the acute complication rate by almost 90%. You could go home and sleep peacefully that your patient is not going to crash.
How long does it take today, the angioplasty?
Today, it's very simple. An angioplasty in simple cases would not take more than 20 minutes. Because the techniques are so refined. The hardware has become, so low profile, and such a perfect hardware is available. The imaging has improved a lot. And of course, the technical training has also picked up a lot. So today is very fast in most of the cases, but complex angioplasties even today would take about an hour. And of course, it also depends how precisely and you want to do it and with what precision you want to do it. Because if you combine, imaging and intravascular ultrasound and optimizing the results, it takes more time. But definitely it translates to a much better future outcome.
So you deal with human heart, like it is the true essence of life. Tell me about a surprising fact that most people don't realize about it.
So Naman, if you really want to know, heart is one organ which just keeps working, and it keeps working even before birth to, till the time a patient or a human being dies. So this is one organ which is always happy and keeps working and never takes rest. Technically, it takes rest while it is relaxing and the heart is relaxing, but it never gets fatigued unless you strain it or if you hamper the blood supply. It's very surprising that God has made such an organ which actually generates so much of a pressure, still doesn't get fatigued, and keeps working happily throughout life, before birth to up till death.
Interesting, sir. Sir, apart from coronary arteries, sir, I remember you have also done an internal pudendal artery stenting. So tell me about this case.
No, we have done many of these now. Okay. We have got the biggest series of internal pudendal artery stenting. Right. That is for male erectile dysfunction. So apart from coronary intervention, my interest shifted to vascular interventions in the entire body. So apart from heart, I do everything from head to toe, artery to vein, whether it is blockages or it is leaking vessels or it is dilated vessel or thrombosed vessels. So, for a long time, people with male erectile dysfunction or impotence were thought to be either having a psychological disease or they were just, pushed aside to taking Viagra-like drugs, which will dilate dilate the vessels and correct the endothelial dysfunction. And, that was the only treatment.
Right.
But many of them would fail this Viagra therapy, and those are the patients we classify or say in technical terms or parlance as complex ED. People who fail Viagra therapy they are grouped as complex ED. And about 20% of the people all over the world after the age of 50 years actually have different degrees of erectile dysfunction. It's so common and so underreported. And many a times the doctors also don't ask about the ED problem. And it actually affects the male in a very major way psychologically. So people were going for penile implants by urologist, which was not a very natural thing. And apart from Viagra, there was nothing. And there were a lot of quackery which was coming in. So when we really looked at it, a small percentage of people who have male erectile dysfunction actually have a problem of inflow of blood. That means like you have a blockage in the heart artery, so you have angina. If you have a blockage in the aorta or internal iliac artery or into the anterior branch of internal iliac artery or pudendal artery which supplies the penis, you will not have a erection. And that was the cause, and the risk factors were same. Like for coronary artery disease, if you are hypertensive, dyslipidemic, you are a smoker, you take tobacco, you have high cholesterol, these things actually lead to a blockage in the pudendal artery, and then this problem occurs. And it's very simple to treat it. The concept was there, and when we actually looked at it, actually, male impotence or ED predates manifest coronary artery disease by 5 years. If you have this sort of a problem, you are very likely to have a coronary artery disease in a manifest form. In another 5 years, it can come as a heart attack or angina. So actually, it's very, very important to ask for this symptom and to treat it, and then look for heart arteries also. And if you have coronary artery disease, the incidence of erectile dysfunction is almost 80%. There have been different studies, especially the PANAPI study and all, which have clearly demonstrated this. Now, treating it, because the internal pudendal artery is the last branch of anterior branch of internal iliac artery, it is very tortuous and it is very thin.
Okay.
So people were really afraid to go there and do an angioplasty. Although the concept was there, people were really worried, and it never took up as a treatment option. So it was long, I think, almost like 99 or 2000 when some people started doing it in US. And there was a trial called Zen trial. So where they there were 5 centers, and they actually, they did a trial in these 5 centers where they enrolled patients of complex ED, and they offered angioplasty, and they found that the results were very promising. Unfortunately, the funding was through a private company, and then this trial actually did not translate into further trials and registries. And that was the time that company which was funding this trial actually got interested in shifting it to Southeast Asia or India. And because that was the time we were, very much into vascular interventions, and that's when I took this over. And we followed the same protocols, and we started doing this internal pudendal artery stenting. And to our surprise, it was very safe. And it was very rewarding in selected patients. Not that every patient of ED requires pudendal artery stenting, but selected patients of ED actually benefit from this, where you can, screen them. There's a way you screen them, and you can predict if this is the cause, 90% can be helped and treated permanently by this. Now, the thing is, subsequently, we did many patients. Now we've got the biggest series in the world on internal pudendal artery stenting as a treatment for male erectile dysfunction. And we are one of the 2 or 3 centers in the world which do it as a regular procedure. So once we have done this, and we also, looked at it, the vascular cause of erectile dysfunction is also venous leak. So people may have a good erection, but it's not a sustained erection, because when you have a erection, you have a increase in inflow and there is a constriction in the outflow.
Right.
So if you have a venous leak, which can be easily picked up on a Doppler study, penile Doppler study, then what to do? That's a more common cause. So now what we are doing is we are embolizing the veins of the penile artery and the outflow. So that actually completes the full treatment for erectile dysfunction, whether it's an inflow problem or an outflow problem. So now it's a very standard, amenable treatment by intervention, and this is probably it should if more people learn about it, actually we can help a lot of our patients.
Great, sir. Sir, when I was going through your prolific CV, another thing that caught my eye was you did a first device closure for aortic aneurysm. Sir, I don't understand anything. Please explain.
So that's again a very interesting case. Let me give you that case. There was a patient which one of the very senior surgeons of the country did an aortic valve replacement. And this patient developed a pseudoaneurysm and was discharged, and that actually bled from the ascending aorta.
Okay.
So there was a sort of a pseudoaneurysm which was leaking into the hemithorax and also into the pericardium. And this patient was immediately collapsed, was managed in a different city where the patient belonged to. And she had almost 13, 14 transfusions and then was airlifted. And it was brought to Apollo. And then the surgeons they wanted to operate, but they found it to be very, very difficult to operate because the patient was in shock, was bleeding. And the moment they would have opened it, the patient would have sort of died. So they were looking for some other, way to treat it. And then they referred the case to me, the whole cath lab, patient had a percutaneous bypass, which is like a heart-lung machine, which was put for an emergency surgery. But so we did a fem bypass, and then I was thinking what to do. Then suddenly it came to my mind that, we can put a device like an atrial septal defect. We can button this, defect with a atrial septal occlusion device. So we tried it for the first time and it worked. The patient improved. It was probably the first case of a device closure for leaking pseudoaneurysm of ascending aorta. And it was published and presented all over the world. It bagged many best case awards. But a lot of surgeons actually thought it's only a, temporary bridge sort of therapy. Right. It's not a permanent therapy. Patient did not want the next surgery. And we followed this patient for 10 years. And the patient did very well. And then we did, seeing this and the presentation, many other people in different places also tried this. So there were many cases, and now it is accepted as one of the primary therapies to treat patients like this. Wow. So it just came out of serendipity. It just came out of, surgeons giving it to you and do something that they didn't want to do it, but still they gave you that courage and the enthusiasm to do, and they were there as a backup. So we did this, and it really worked. So sometimes it works like this when your colleagues actually give you a case and stand by, and you want to do something clicks your mind, and you do it as a desperate measure, and it becomes a standard of therapy. Same thing happened, when we started another similar sort of thing in acute massive pulmonary embolisms where there is a total contraindication for lytic therapy or anticoagulation, right?
Okay.
And then I remember a case where, 130 kgs guy who had a road traffic accident and just came to the hospital. Patient was bleeding, had a neurosurgery, and developed a massive pulmonary embolism. Surgeons couldn't do anything. We couldn't anticoagulate. They just wheeled in the patient to our lab, do something. And that was long back, and I just figured out what to do. I didn't understand. Then I said, that time we used to have big, guiding catheters for directional coronary atherectomy, which is no more done now. I said, let me take the catheter and try to suck out the clot if possible. And we did it. And actually the patient got stabilized on the cath table itself. So then again, we presented as the first case for manual thrombosuction of pulmonary arterial clots in patients where there is a total contraindication for lytic therapy or anticoagulant therapy. And then as the word spread, many such cases started coming in. So again, we had the big A series we published. Now it has a class 1A indication in the guidelines. So,
wow. So
these things happen when, you get the case and you have to do some out-of-box thinking, and there are people who support you, and it's a desperate life-saving measure, and then it becomes a it's replicated by many operators and it becomes a standard of care.
In fact, sir, there is one more thing which I can see from it, that publishing your work is also important.
Very important.
Even for young medicos, how they should learn how to do research, how to publish the work. Sir, any advice on that?
Yes, definitely. When we train in US and Europe, the word was that if you don't publish, you perish.
Okay.
So you have to publish your work. It has to be authentic work, and it has to be with a proper discussion and review of literature. And that's how you get noticed. And many people who notice actually bring in new thoughts to this concept. They many a times improve on this. And slowly you get to a therapy which is very, out of the box, but very new and novel. And these become the standard of care. That's one part. But if you don't publish, your good work is not recognized. It's very important for us, especially India, that we do such phenomenal clinical work. Our expertise, I don't think any country can beat us in terms of expertise and the clinical knowledge and the skill sets. But where we lack is the research and presentation and publications of what we do in a more scientific manner. So if you look at our publications, they are mostly as case reports or, in journals which do not have high impact factor, which are not sort of picked up by good researchers or good operators across the world. Today it's become easy, even those journals which are not very popular with high impact factor, but with Google search and other search engines, you actually can pick up those good work also. But publishing and developing that scientific temper and academic temper is very important, and I think that should be one of the main focus and sort of a mandatory part of teaching in our curriculum in India. That's where we lack, and that's where people in the West actually score over us.
Right. So, in fact, you have got more than 150 publications, and I noticed there were a lot of publications on AI in cardiology. So, can you please explain?
So, AI, again, that's the in thing. Now, everything you talk about today in every branch, medical, non-medical, is all AI based. It's something like, say 20 years, 15 years from now, before us, before today, is like the state in which the computers and laptops and, mobile smartphones were there. Today, everything is dependent on them. The next 15 years, we see everything is going to be AI based. It is still going to that stage. So one has to know and take help of AI. It's an artificial intelligence, but soon is going to be an assisted or intelligence. So you have to take advantage of AI in everything. Now, what really got me into this was, the Microsoft actually did a project with Apollo.
Oh, yes, I read about it. Apollo Microsoft Cardiology Project.
Yeah.
Yes.
So, they actually teamed up with Apollo, and we wanted to develop software and risk profiling software which could actually predict the incidence of coronary artery disease and vascular disease, taking into account the inputs from the health checks which we do in Apollo.
Okay.
And that we wanted to verify this risk scoring vis-a-vis the most standard scoring systems which were there in the world, like Framingham studies and other studies. And we had a huge database.
Right.
Dr. Sangeeta Reddy she was very passionate about it, and I remember we used to work on it, me and there's another of our very dynamic cardiologists from Apollo Secunderabad, Dr. Shiv Kumar, and we got into this, and then we got this, predicting model using artificial intelligence, and we got it validated against the different, risk profilers all across the world, in many centers in Oxford, in US, in Mayo Clinic. And this was one of the most accurate one and much, much better than the other ones. And because we not only took the conventional risk factors, we actually took a lot.
Expanded it.
We had many more risk factors there. And also that we our data pool was much bigger because Apollo had a huge database. And so we got this, and then now you see Apollo Pro Health and all, it's all using this sort of our own software. So we are much more into this, advanced into this. So when we did this first project, we got excited into it. And then, actually, once we were dealing with engineers, so I made friends with many more engineers and, postdocs. And then we got introduced to a group of doctors who were actually working on imaging in cardiovascular disease and use of AI in that. So we had different models, and so we have a company in United States and based out of United States, but we have data from almost 35 countries all across the world. And we have created a very strong AI-based, imaging and predicting models. And now they have been validated, and they are being used by, some big insurance companies
to
in
predict
Middle East.
the risk of
It's not only to risk of cardiovascular disease,
right.
That's one, but now we have, apart from the conventional risk factors, what we do is we image the carotid arteries through an ultrasound, the intima, media, and there are different things which we image. We also image the, CT images, and with these sort of parameters, we can predict a lot of things. So we have, apart from coronary artery disease, we have now expanded into strokes, sleep apnea, erectile dysfunction, and even during COVID, we had a big AI-based, diagnostic and predictive model for, the risk factors and mortality in COVID patients. So we are into rheumatoid arthritis. So there are a lot of research things which are going on. So it's now a group of more than 40 people across the world who are working on different papers, and you've got a paper publication in Nature, you've got in Lancet, we are published, submitted in Lancet, you've got in almost all the best journals in medicine and also on engineering side, because this is a group which is a group of engineers, hardcore engineers and cardiologists.
So international collaboration.
So it's a consortium of international people who are from different fields.
Sir, what suggestions do you have for young medicos like us? How do we keep ourselves updated on the current status, AI, so many things happening around the world?
So the young young doctors should actually look at two things. One, skill set and clinical training. The other is to actually learn whatever new is coming. So that comes from awareness. The awareness could come from attending conferences, from reading literature, from publishing, from actually networking with like-minded academic doctors, engineers. It's very important for the doctors and engineers to actually, interface with each other and collaborate, because they learn a lot from us and we learn a lot from them,
Right.
I'm saying because I've done it while during my, fellowship in France. So I worked with some innovators and they were also free. They were developing something with Dr. Michel Henry, and I was from the medical side. So I know how they think, and they are very excited to know what we want and what actually how we think and how the things work. So that's a very important, networking or collaboration, which is important. And this cross training should happen, I think, from the MBBS level, from the PG level. And then, we saw it during my fellowships in US also, that there is always a sort of a, interaction which goes on. And that's why they invent so many things while we have concept, but we don't.
Yes, sir. In fact, some of the greatest orthopedic surgeons and the inventions they have done are in collaboration with the engineers, because the implants and everything.
Yeah. Even on our side, cardiology side, if you look palmar charts, so one is a doctor, one is an engineer. Okay. So, most of the devices are a collaboration between doctor and engineer.
Right.
Even if you look at Chitra valve, which is I think the most, in terms of number, I think is one of the most popular valve and very cheap valve developed in India. Is a collaboration between engineer and cardiothoracic surgeon.
Okay, Chitra
valve. It is from Sri Chitra Institute in Trivandrum.
Wow.
And it is now, then it was sold to TTK, and now it's TTK is the company which markets it. But it's a very low cost and a very efficient valve. So that is what, I think awareness, presentation, networking, and cross collaboration between doctors and engineers. That is what is very important. And I recently visited and gave a lecture in IIT Kanpur. I'm a visiting professor there. I was intrigued myself with the startups. I was made to interact with startups, and they have such brilliant ideas, but they have little knowledge of medical profession, and we have no knowledge of how they think. If the two can be braced or married, excellent things can come in. The doctors have greatest ideas and skills. Those guys know how to sort of, put your ideas into practice and innovate things.
So talking about training, you have trained multiple cardiologists over time. So what is one trait that you look for in a cardiologist when you are training them? Or what should a cardiologist aim for in his CV to impress you or to be mentored by you?
Okay, so let me answer this in 2 points. I train cardiologists and vascular surgeons and radiologists.
Okay.
Because I do both cardiac work and interventional vascular work. I think what is most important is, for me, is the type of training a person has. And I would prefer a person who is raw, is not like, doesn't have the good or bad reflexes. He can start from stage 0, but he's got that fire in his belly to learn and work. These are 2 things, that he should be ready to learn and have a hunger to learn and also work. It should not be like a 9-to-5 job. So that is the type of people, I think they are the future. And if you look at it, most of the people who have really made it in cardiology or any medical field are the people who have this trait. They may not be the brightest student, they may not be the toppers of their batch, but because of this, that hunger to learn and in terms of excel in skills, and never dying attitude is, they would have the perseverance, they will have the thing that they would work their guts out to actually achieve it. Those are the guys who actually make it to the end and at the top level. And I have 90% of people who are achievers have these 2 traits. And of course, when I say this, of course, it has to come with humility, because if you think you know a lot, you will never learn. Now, if you're looking at the CV, what I look at, of course, I look at, from the institution from which a person has come.
Okay.
Of course, the publication and the type of publications, and the type of people under whom he has been mentored. That actually, if somebody is mentored by a great mentor, his, the entire thought process, his whole personality changes, and then he can learn very fast. So that is the 3 things I look for. And I believe those are the things which, even if you go abroad, that is what people outside also look. So it's your publications, the quality of your publications, of course, experience, and the recommendations. And these recommendations are very genuine outside, and they carry a lot of weightage.
Okay.
So I've been very fortunate to get very good mentors, and that actually defined my career and career growth also, because I was taken up into the highest slots of interventional training, like I was joined straight away on the 7th year of interventional training. So that's because of good mentorship and these factors. So they actually, weigh a lot in terms of selection outside India. But in India also, this carries a lot of weight.
And sir, what mistakes do commonly young cardiologists do under your training? Or
I won't say cardiologist, would be the same thing. I mean, the biggest mistake is, not trying to learn in a very short period of time. One has to understand that it takes time to mature yourself in terms of clinical skill and also a mature thinking and safe thinking for the patient. So there is nothing which beats your experience and time.
Right.
The second thing, many of the younger doctors think that they just, want to do their logbooks. They have done so many cases, so I'm equivalent to my mentor. That's never the case. What is very important is and if I was being trained, I was told by Dr. Seth, which I still remember, one of the best things, when I was going abroad, he told me, what you should learn is not the skills. Of course, you learn the skills by doing it, but the thought behind the intervention, thought behind the procedure. If you can master that and match that from your mentor, then you will learn. And I think that is the key.
Even in orthopedic surgery, sir, I believe as an assistant, you can learn a lot if you can predict what the chief surgeon is going to do as the next step.
So because that's what your mentor actually, that his thought process is after 30, 40 years of good practice. And he's seen all the complications.
Right.
If you can match it and you're smart enough to learn that, you can avoid so many complications and you start from a very high pedestal. So the youngsters today actually don't focus on this. So this is something I would advise youngsters to. Of course, time is important in their training, but there has to be humility and a very sharp, your antennas have to be very strong and sharp to actually learn this sort of things. What the expert actually, how he thinks and why he thinks.
Right. Sir, talking about interventional cardiology, you mentioned you work with almost every vessel in the body. You train radiologists, you train cardiologists. Sir, what exactly is the difference between a regular DM cardiology and an interventional cardiologist? How does one become interventional cardiologist?
Okay, so, unfortunately, the training in India and maybe outside also is a very long training. So you have to do 5 years or 4.5 years of MBBS, then 1 year of internship, then 3 years of general medicine, and then 3 years of cardiology. So it almost, becomes 12 years without a gap to be a cardiologist. Now, once you're a cardiologist, you are just certified as a doctor who has seen enough of cardiac disease and can do simple procedures and actually can diagnose. But you're not a specialist.
Right.
You're classified as a subspecialist or super specialist in cardiology. But there is that actually is their starting point for your skill training. The skill training actually starts after this. So you have dedicated courses, which are known as, there is one called Fellowship, National Board of Interventional Cardiology, FNB.
Okay.
But most of the places in India, you are mentored by working 2, 3, 4 years with a senior interventional cardiologist, and that's when you pick up these skills and you are trained to do independent cases and mostly all sort of cases. Abroad, there is 3 years or 2 years of training, and that's known as fellowship or diplomat of interventional cardiology. That comes in after this, after cardiology training. So
even DM is not enough.
DM is not enough. DM makes you a cardiologist, but if you want to do complex cardiac procedures, this is not enough. Secondly, DM is just a generalization because cardiology has evolved into so many branches. So you have pediatric cardiology, you have electrophysiology, you have vascular interventions, you have structural heart intervention, you have interventional cardiology, which is dealing with coronary arteries. Then you have, cardiac imaging, you have heart failure as a branch in cardiology. So, and then you have now genetics in cardiology. So,
wow.
And then clinical lipidology and cardiology. So you have 8, 9 branches. So, in today's corporate world, it is almost mandatory that you specialize into one of these or 2 of these, and then you build your career there. Otherwise, with so many seats around in today's time, it becomes very difficult to, excel and find your own place and own niche area. So interventional training actually requires another 3-4 years after cardiology, but you are licensed to do anything in India after doing your DM or DNB in cardiology.
And sir, you talked about competition, especially in corporate world. Sir, I know there is too much competition for DM cardiology as well. And how bad is the job saturation situation? How much is the risk versus benefit for being a cardiologist today?
Okay. So if you talk of competition, I don't think there's so much of competition now. It used to be a big competition. When we were there, we had only 27 seats in the country.
Okay.
And people were waiting for 3, 4, 5 years. They would do non-DM residency and then get into appear for interviews and get into DM cardiology course. Today, there are almost 600 seats, DM and DNBs. So there are a lot of seats. The good thing is we are producing more cardiologists, but the bad thing is that, there's no standardization of training across institutes. At some places, you may have excellent training in cardiology, and at some other places, the training is very poor because the work is very low and not of that standard. Unfortunately, the students who go there may be very bright students, but may not do it from the best centers. So this is something which needs a lot of attention by the national board or by the National Medical Council. And so competition to get into cardiology, I think there is more competition to get into medicine rather than getting into future cardiology. Now, where the competition actually comes in is you become a cardiologist, but you need to find your niche area and your name and your practice. So that is where good training is important, ethics are important, that urge to be the best and, to do a lot of good work. That is where it comes in. Of course, what also comes in is, the way you practice, how you build up your practice, networking, marketing, all those things come in then. So the real competition in cardiology today is after you do your cardiology, not getting into a cardiology course.
And sir, for an average cardiologist, is the salary good, bad, or high? What would you say?
I mean, that's again a relative thing, but average cardiologist would earn, to start with, somewhere around 3 to 3.5 lakhs just after DM. Okay. If he goes to, say, a tier 2 or tier 3 city, he may start with 5 lakhs, 6 lakhs, 8 lakhs, 10 lakhs. So if you go to cities like tier 2 and tier 3, your startup salary is very high. But if you come to big corporates and metros, I think you start with 3.5 to 4 lakhs, which is not bad. Which is, to start with, it's not a bad salary. And then you build up. Then it sort of becomes high as you grow, quite high.
Sir, you have helped setting up centers all over the country and in fact abroad also. Sir, can you please enumerate how many countries you have set up centers in, and do you have some story to tell?
Yeah, so I mean, that's again, it's very, if I recall the whole thing, I feel very good that, I was helpful in establishing centers, and we established 5 centers in Vietnam and Ho Chi Minh City, and they are now doing very well. We established 2 centers in Malaysia, 1 in Indonesia, and I think 3 centers in Bangladesh, and 2 centers in Nepal, apart from many centers in the country. When I say centers, I talk about cardiology and interventional cardiology, that setups. And so we've done it in a way that we initially got people, from Vietnam and from Indonesia. We actually had an MOU to train them here and then to develop the centers there. So we got the doctors from there and we trained them here and then went back and developed the centers there. We've also done it in Nigeria. So I've trained almost 11 or 12 cardiologists who are now leading the centers, 10 or 11 centers in Nigeria. So it's a very good feeling. And actually it was an involvement of their government and Apollo Hospital or Escorts, and a sort of a collaboration where we developed this. And similarly, within the country also, Escorts used to be one of the pioneering institute, and it helped to develop many interventional setups all across the country, especially North India.
Sir, you have also operated in multiple cities, right? So how many cities like you?
So I mean, I have operated in many cities. I still operate in many cities as a I am actually a proctor for many new and complex procedures and devices for aortic aneurysms, complex aortic repairs, and different techniques and devices all over the country. But we used to have many centers associated with Escorts initially, and then Apollo, where we used to sort of support their cath labs, go and do work there. And they used to keep complex cases or cases which were newer devices or newer techniques were required. But we were also crazy at our younger days, where we were in a sort of a competition to do more and more cases and do it in different places. I still remember long back when I was in Escorts, I actually did interventions in 4 cities in 2 countries. So I did cases in the morning in Escorts, then afternoon we took a flight and went to Raipur. We did cases in our center in Raipur. Then I went to Varanasi and did cases there, and took a flight to Kathmandu and did cases in the night. So in 24 hours, actually worked in 2 countries and 4 cities. But
so those were complex cases or pretty straightforward cases?
Those were, except 1 or 2 of them, most of them were pretty straightforward.
Okay.
And not very complex ones. And because when you are doing such cases, you don't want to do a complex case and then just leave the patient. And those were the times when complex cases, at least for coronaries, were sent for surgery. So we were not doing triple vessels and left mains and calcified arteries at that point of time when I did this. So that time, it used to be simple things were for angioplasty, and then the complex things were for surgery. But today, no such differentiation doesn't occur. So in fact, we do more interventions today than surgeries. And now we do calcified arteries, we do triple vessel disease, all in one sitting, left main disease, multiple blocks in a poor left ventricular function. So these are the routine things, because the devices, the hardware, the technology has improved so much, and also the clinical experience has grown.
Sir, what is an absolute contraindication? I mean, what you would not do, but there has to be a CTVS surgeon who will do it. What disease would that be? It stems from the fact that I remember as an MBBS student, triple vessel disease was a contraindication for stenting.
No. Yes, triple vessel was a contraindication. Left main disease was a contraindication. Exactly. Triple vessel or single LED with LED dysfunction was a contraindication. Now, these are the routine cases which we do.
So, is there anything left?
If you ask me today, in terms of coronary artery disease, I wouldn't say there is anything which the interventional cardiologist with experience and expertise cannot do. In fact, but what is very important is, if you have to do, coronary artery disease with, with a aortic root replacement or a Bentel procedures, those can't be done with intervention as of today. Secondly, what is very important is if the patient has renal dysfunction, allergy to contrast, then you can't do these things.
Right.
Third, it's also the fact that, when I'm saying that it also depends on the expertise in your center, with a surgeon, with his interventional cardiologist, and the backups. It's not that I can do it, so I should do it. If you look at the whole teamwork, and you see you have the team of anesthetists, interventional cardiologists, and surgeons, so whosoever is best and most experienced should do that. When you are saying that we can do all these complex procedures, we require a lot of hardware, we require a lot of backup, equipment, and also the cost becomes a prohibitory factor. So this intervention becomes costlier than surgery. So it's always a mix and match of the two.
And a teamwork.
And I think if you really want to grow, the surgeon and cardiologist have to grow together. It's not a competition, but it's a complementary sort of a procedure. In fact, I feel that now the cardiac surgeons of today actually are getting the worst of cases. It used to be very simple cases earlier. Now they get cases which usually cannot be managed by average interventional cardiologist and the newer technology. So their cases are now high-risk patients and very complex artery, calcification, diffuse disease.
Right.
They have to do, atherectomies and then put grafts. And so they have a different set of complicated patients which they are doing now.
Sir, what would be the most complex procedure you have ever done?
Complex, that's a difficult thing to remember.
Maybe should I rephrase it?
Because I normally, I get more complex cases now. I don't get simple cases because now angioplasty is done in many centers in almost all cities of the country.
Right.
So what we get in tertiary centers is mostly complex cases. And they have complexities because of different reasons, both in coronaries and non-coronaries.
Okay.
But
do you remember a case?
You can talk about, interesting cases, and let me give you an example. The interesting cases are very important, and they're all complex in different ways.
Right.
I do remember I had a young guy who was just 22 years or 21 years. Young guy, smoker, came to look for a job in Delhi, had a cardiac arrest, and was brought by bystanders to the hospital. I think it was a Sunday and morning. And we had no history. We didn't know what it is. But we had very good team in the emergency who could do a good, proper cardiopulmonary resuscitation. And we continued almost for 1 hour and 20 minutes or 25 minutes. And the patient wouldn't get back his rhythm or circulation. And practically according to all guidelines, the patient should have been declared dead.
Right.
But it continued, and because the CPR was good and he was so young, we actually continued this and cooled his brain. So intuitively, we cooled the brain.
Cool the brain, sir.
What
exactly is?
What we do is we put ice packs and to get the brain temperature down, so the oxygen requirement is decreased.
Okay.
So even if you get this patient, he recovers later on, he actually doesn't chances of becoming brain dead are much less. So that was intuitive, and then we had no clue what to do, but we wanted to save the patient, and there was no money which was deposited, there were no attendants, blood relatives. So, but we still took the consent from the hospital authorities, and I took the patient to the cath lab, and we actually did his angioplasty with massage on for more than 1.5 hours with no circulation and brain cooling with all the LV supports, left ventricular supports.
So the massage was going on with the angioplasty?
Yes.
And the brain cooling was also going on?
Brain cooling, massage, left ventricular supports. And of course, the patient was intubated, and we did a thrombectomy, and there were repeated injections of, intracardiac injections of adrenaline. And slowly, the patient's heart, we could take out a big clot, and the heart sort of started pumping, although the PP was low. So we kept the patient on the left ventricular supports. But the patient clinically looked comatose for a few days.
Right.
And then the patient started, we were talking about brain death and all, but patient started recovering. He was a young guy. He actually recovered. And today he is, he's an engineer and he's got a good job. He actually, became our ambassador because he was a smoker. And he sort of goes with me to all these colleges and actually tells young students why not to smoke and what can happen with smoking. But it was one case which was, I would say, not very complex to do, but very rewarding. And we combined a lot of things. Again, this patient, because it was such an incident, it got very widely published in the national and international newspapers and all. But this is one-off case. Normally, as you say, that, you can revive a patient 1.5 hours after CPR. Yes. It is sort of impossible, but right. this patient, we did this, it worked out.
Wow.
And it was a combined effort of very good, paramedics in the emergency and the whole cath lab staff, and it worked out very well, and our team in the ICU. So these are cases which actually were complex in one sense, were very intuitive, that had we not cooled the brain, the patient heart would have recovered, but he would have been brain dead. And also the fact that he had the luck on his side.
Right.
So this is the most complex ones. But if you ask me, cases which I do remember is, emotionally, it would be doing angioplasty on your own father, who was like 86 or 87 years at that age. And a very complex lesion, again, calcified.
Cardiac surgeon himself.
And to do it, it was like when your colleagues say, why do it on your father, get somebody else.
Right.
I asked my father and mother and brother, and all said, no, you do it. And then, so, and it's again a very complicated calcified lesion.
Was it elective?
It was an emergency.
It was an emergency.
It was like a he had acute coronary syndrome.
Okay.
So you have to do it. And I just landed from France up from a meeting, and I was told it's having ACS. So he came to the hospital. I came from the hospital from airport, and we did this. So those were, but the good thing is, I didn't get disturbed because you cut off as a, son, you are acting as a doctor, and he cuts off as a father, but acts like a patient.
And most of these procedures are done in awake patients.
They're all awake.
So
at
the screen and talking to you.
Yes. And he being a surgeon knows what's being done.
Okay.
So that's also interesting. And then what runs in the background of your mind is the list of complications which can happen.
Right.
And where to stop. It's a very calcified lesion. So it's and I remember it at that time you are cool and you can do it because of your emotional and technical training and skills. But later on you start thinking of many things, what could have happened and what maybe you could have done better, or you have always have that sort of afterthoughts, and then so that sort of thing which sort of troubles you later on is 2-3 days you go through this. You take I took many advices from the top guys in the world, and just to be sure that everything which was done was correct, and had they done it differently if they had this case. So those are the cases which you really remember emotionally. And that was one of the most interesting, and the case which I would remember is doing it on your father at that age. And with all the hospital cardiologists and doctors saying, you shouldn't be doing it. Don't do it. Let somebody else do it.
Right.
So those are the things. But
Sir, you talked about this young guy who was a smoker. Sir, I get this question a lot from my non-medico friends as well about smoking and heart disease. Sir, how many cigarettes are too many? Some people say we just smoke 1 or 2. For orthopedic purpose, 1 or 2 can cause non-union of a fracture. But how does it work with
if I really want to put it correctly, even passive smoking is not good. That is also equally harmful,
Okay.
As a cardiologist or any doctor, you just can't advise anybody to smoke. Even 1 puff is bad. Even passive smoking is almost as dangerous as you smoking many cigarettes a day. In fact, sometimes people say it's more harmful. So smoking is a complete no to prevent cardiac disease. You won't believe, every month I do 1 or 2 cases, or I see 1 or 2 cases. Young guys in their 20s or maybe in their teens getting heart attacks because of smoking.
Even teenagers?
Even teenagers.
Wow.
So a lot of young, I don't think today that, in terms of age of having acute heart attacks, I don't think there's any age. Maybe I would say 15 years and younger, you may not have it, but anything after that, we have seen it. The youngest patient which I have done and who got a heart attack was a 17-year-old girl.
Oh, was it related to smoking, or was
it wasn't related to smoking? It was related to inflammation in the arteries and taking oral contraceptives. But 18, 19, 20 is a very common age. So in my own hospital, I've got, many children of the staff of the hospital getting attacks when they were gymming, when they were running, when they were sleeping. And the only risk factor is smoking or excessive gymming.
Oh, sir, please explain on the gym aspect as well.
It is, I would. And this is something which actually should be taken very seriously by the younger people. Smoking, absolutely no. It can cause a heart attack in a normal vessel. What actually, if you see the arteries of these people, they are absolutely normal. Only at one point, the plug ruptures or there is a clot formation and patient has a heart attack. If they are not treated in time, they lose their life, or even if they don't lose their life, their heart becomes so weak that they become a cripple, cardiac cripple.
Okay.
So this is one thing which has to be avoided. One has to understand smoking can cause heart attack or strokes in a normal arteries as well.
Can you take aspirin as well and continue smoking?
No. No way. Aspirin is, you have asked a good question. Aspirin, everybody should have a chewable aspirin at home.
Okay.
It's seen by trials that if you chew a tablet of aspirin, if you have a heart attack, your mortality comes down by 50%. So in your medicine kit in every house, there should be a chewable aspirin. It should not be swallowed.
Okay.
It should be chewed.
Okay.
And then, of course, you rush the patient to the hospital or the nearest facility. But taking aspirin at that time will reduce your risk of dying from heart attack by 50%.
Okay.
Is that important? But to take aspirin and smoke, no. Absolute no.
Okay.
So smoking is a total no.
Right.
And most of these younger heart attacks happen because of smoking or tobacco or drugs. And
sir, if a chronic smoker stops smoking, let's say he smoked from 25 to 35 years of age, and then he stops after that, how long will it take?
Okay, so let me put it, I'm just talking of cardiovascular risk.
Right.
In terms of respiratory complications, it will be different. In terms of risk for malignancies, it will be different. But if somebody is a reformed smoker, then he has the risk of, which is equivalent to a smoker for 5 years. After 5 years, his risk of having heart attacks actually becomes equivalent to a non-smoker.
Okay.
But the time in which he has smoked, he probably must have developed blockages, fixed blockages, which we call as stable plugs.
Oh.
So these stable plugs can cause angina, but the risk of having heart attacks, acute coronary syndrome, is reduced after 5 years.
Okay.
But till 5 years, he has that risk. And whatever damage had to happen has already happened. So it will only prevent an acute heart attack or future progression.
But it will not be reversed, the damage?
No.
Stop?
No, actually, no.
Okay.
I mean, blockages in the heart arteries, even with the best of statin therapies and anti-inflammatory drugs, can only regress by, less than 5%.
Oh.
And that is insignificant in terms of the percentage of blockage. So what it does, if you change your lifestyle, you give high doses of statin, you stop smoking and control your blood pressure and diabetes, the plugs which are very vulnerable to, rupture and causing acute blood clotting and a heart attack, they become more fibrous and stable. So you may convert an unstable plug to a stable plug. You may actually, what it leads to, your risk of dying or developing heart attack is reduced, but your risk of, the risk of developing fixed blocks and having angina on exertion or finding a block 80% on the coronary angiogram, those are there, which can be managed by medicine.
Right.
So acute coronary syndromes will actually, the risk is going to decrease with all these modifications. But whatever plug has built up, it will be there, and it's almost insignificant. There's a very little regression of the plug. Only thing, it becomes more fibrous and stable.
But it's beneficial to stop.
Absolutely.
Even after being a chain smoker.
Absolutely.
Okay.
I mean, your risk of dying out of heart attacks and risk of developing heart attack is reduced significantly.
And sir, can you tell us about these gym A lot of young people are crashing in gyms. What's going on?
So 2-3 things are happening. One is excessive gymming and, having a misconception that a very 6-packs, 8-packs body is the best body and a sign of health. That is not true. And what happens is people go to the gyms and start with very aggressive gymming. And if you are not trained and if you don't do it, build it up over many weeks and months, your plug gets ruptured. It's the same phenomena which happens with smoking. Suddenly you have some weak spots in the intima or endothelium of the heart vessel. Suddenly there is a stress on that. It ruptures or fissures. And then the platelets, and the blood clotting factors would go and adhere there and form a clot and cause a heart attack. So that's one part.
Okay.
The second thing is the food. Sometimes these energy boosters or supplements, which these gym instructors give without doctor's advice, they are the ones which cause this. And the risk of sudden collapse in the gym or after gymming is many times related to electrical phenomena. So one has to understand that deaths in the gym are not only because of heart attack, but most of them are because of cardiac arrest. And cardiac arrest is a electrical short circuiting of the heart. So what happens is there is suddenly a ventricular fibrillation or a ventricular tachycardia, and that is again that could be triggered by a plug rupture. That could be triggered by this sort of excessive gymming without training. Third, it could be triggered by the energy drinks which are given. And fourth, which is very important, many people, I will not say many, but some people have congenital channelopathies, genetic disorders of conduction system, and they have cardiomyopathies, where this trigger because of exercise can actually trigger a ventricular tachycardia and sudden electrical cardiac arrest. So these are the things which are important, and that is why, if somebody goes into heavy sports or heavy gymming, one should have before joining the gym, they should have a checkup, at least an echo. If there is a history of sudden deaths in the family or young deaths, sudden deaths in the family, then in that situation, it's very important if somebody is going for gym or even otherwise, they should have an echo to at least know, and an ECG to at least, predict their risk of sudden cardiac death or strokes within while they are gymming or doing heavy exercises.
So 2 things, echo and ECG. And of course, go slow on training.
Absolutely. It has to be a slow way you go up on strength and endurance and cardio. Second, while you're doing it, also one has to understand that it should not be that, a person at my age would suddenly go and wants to develop 6-packs, 8-packs, and he does just follow the gym instructor who is 20 years old and he pushes him to an excessive gymming program.
Right.
That's where the problems occur. And I think it must be the same in your specialty also.
Yes, of course.
You would get many patients with knee problem doing excessive treadmills.
And a lot of tendinopathies we get because of the gymming, a lot of biceps ruptures and those things. Yes.
So these are things which are more media driven and
right, absolutely.
And it's a different concept of health which has now come in.
In fact, sir, I believe in my profession, there is no collaboration between a trainer and a physio or a rehab protocol. So all of these are working separately and have their entire different protocols and everything. The trainer works like a physiotherapist and doesn't know either. And a physiotherapist would also work like a trainer, but not concentrate on physiotherapy. So there has to be some collaboration or connection. That's what
absolutely true. And the same thing is happening in cardiac issues also. The trainer would say he's doing a cardio. He doesn't know ABCD of a cardio workout.
What exactly is cardio?
What is cardio? What is cardiac rehab? He doesn't know about the cardiac reserve. But because he just says cardio and cardiac fitness, people get into this trap.
Sir, how important is the stress, mental stress, emotional stress leading to a heart disease? For example, there is a syndrome called broken heart syndrome. Can you please elaborate on that?
So initially, broken heart was like more of a poetic term, and then, but we all saw that, if there was a sudden grief or sudden excitement, people were dying. So it was actually, taken into more serious consideration, and especially by Japanese, who sort of worked on this broken heart syndrome. And now they have come up with a word called Takotsubo myocarditis or Takotsubo cardiomyopathy, where what happens is, because of excessive release of catecholamines, there is dilatation of the ventricle, sudden ballooning of the left ventricle, and electrical instability of the left ventricle. So these patients can suddenly die because of heart failure, cardiac arrest, or sometimes even ischemia of the heart. But if you look at their coronaries, they are normal. And this is because of excessive catecholamine release. So it's not only a poetic word, it is not a mere coincidence, it is a proven fact now. And these things actually recover. In 3 days, 7 days, 10 days, if you look at it, patients' cardiac functions come back to normal. So broken heart syndrome is a very, a sort of a real thing. And everybody should sort of prevent this by a natural, the psychiatrist would say, a proper defense mechanism. So one has to accept the realities of life. One has to accept the frailty of life, and also the emotional things which happen in your life or in other people's life. So that is very important. I have seen one of my colleagues, he had 2 sisters. One had a rheumatic heart disease, mitral stenosis. She died in the hospital. The other one, who was normal and attending to her, died because of shock. So 2 of his sisters died just because of, one had a cardiac problem, one had no cardiac problem, but developed
broken heart.
Broken heart syndrome and collapsed and died. So these are a reality, and I think again, it comes back to the mental health. One has to now very seriously think about the mind and mental health. The mind, heart, body, they are very intricately related.
Right.
It's not only that you develop cardiac problems, you also develop cancers, you develop so many other problems. So mind and heart is a very important connection.
Sir, we have talked about smoking, exercise, and some risk factors. Sir, alcohol as a risk factor, what do you have to say about that?
Naman, that's a very good question. You would see and hear a lot of cardiologists saying, thoda 1 or 2 pegs are good for the heart. But the literature says the opposite. Any amount of alcohol is bad for the heart, and not only heart, for brain as well as liver.
And red wine?
Any wine, any form of alcohol is bad for the heart. What it does in maximum is it increases your good cholesterol by a very little amount. But it has so much more side effects or detrimental effects, like increasing your blood pressure, increasing your risk for diabetes, and, reducing your cardiac functions. So it is not at all good for heart. Alcohol in any quantity is bad for the heart. It's toxic for the heart muscles. It sort of, if you take it for a long time, it raises your blood pressure and, insulin resistance. It increases your blood sugar and indirectly affects your heart. So, and it makes your heart electrically unstable.
So there is some safe limit according to UK standards, 14 ounces.
Okay, so let me put it what has been in countries where they take alcohol.
Right.
Number 1 dictum is, if you are not an alcoholic, there's nothing there's no prescription as good alcohol prescription. You should not take it.
Okay.
If you take alcohol, then the safe limit is 1 to 2 small pegs once or twice a week.
What's a safe limit?
That is a safe limit, and it's a beneficial limit which doesn't affect your heart adversely. Okay. But even this amount of alcohol actually affects your liver and brain adversely.
Okay.
So you talk to any good hepatologist, they would say absolute no to alcohol, as we say for smoking for heart. And also a neurologist would say no to alcohol. But if you go by guidelines as of today, which comes from West, not from India, is that a person who is taking alcohol, 1 or 2 small pegs once or twice a week, is all that is allowed. Second, if you go to one of the biggest studies in nutrition and lifestyle management vis-a-vis heart disease. So this study, which is known as the Inter-Heart studies, this is a study across many continents, different countries, where they have clearly shown that alcohol is bad for heart. Any amount is not good for heart.
Okay.
It also depends the way Indians take alcohol and the way Westerners take alcohol is very different. Apart from the climatic condition and all, they would take very small sips of alcohol with food, and they would take it over a very long time. I mean, their supper or whatever takes a very long time. They will take X amount of alcohol over 1 hour or so. Indians will be more like a binge drinking. They would drink alcohol without enough food in a very short time. So that is the difference. But this study is like one of the biggest studies, has clearly shown the detrimental effect of alcohol on heart. There is no benefit, and especially in Indian subcontinent, there is no benefit. It is a risk factor. And secondly, it also talks about different nutrients and lifestyle modifications to prevent heart disease and how they are a risk factor for heart disease. So many things are there. The way Indian food is there, it's a bad food. It's very oily. It's rich in cholesterol, rich in trans fats. It is rich in carbohydrates. And the way it is cooked is also very bad. Raw food is good. All this data has come actually from this study. The way we cook our food, it is detrimental, and it is actually not only carcinogenic but very atherogenic. So, so this is a myth. You will find a big divide among cardiologists and physicians. You will find many cardiologists and physicians actually taking alcohol. But if we talk about the truth about it, the scientific truth, it is bad. Having said that, if somebody is taking alcohol, then this should be the limit. If somebody is highly stressed out and suppose it helps him in reducing the stress, yes, this small limit is all that is permissible. But nobody should go with an idea that taking small amount of alcohol is good for the heart. It's not good.
And what exactly is holiday heart syndrome?
Oh, holiday heart syndrome is actually when you take binge. You drink alcohol in large quantities over the weekend, and then people would find that they don't get up, they get cardiac arrest and many things. And this is because excessive dose of alcohol actually makes your heart very electrically unstable, and you have these ventricular arrhythmias, and some people would die out of it. So this is like, this is usually effect of binge drinking, large amount of alcohol over weekends or holidays. So again, this pattern of taking alcohol is not good. I mean, if you see people who drink on weekends, and especially in holidays, and when they are actually traveling on holidays, they would take a liter of beer and a lot of alcohol, and then just go to sleep and take all the, take smoke along with it. And some of them would not get up because of electric cardiac arrest because of arrhythmias.
So, talking about training young minds, sir, would you be willing to take some observer or a fellow for, let's say, 2 weeks or a month? And for example, if we find someone and ask you to take him as an observer, would you be willing to do that?
Yeah, absolutely. I mean, we love to do these things. We get many people to come as an observer. It could be young people, it could be old people. Or also we get a lot of people from abroad on their externship programs. So not only that we love to have them, but we also learn a lot from them because they are young, fertile minds. They come up with a new vision in a new world. So we also learn a lot from these people.
Sir, you also said that there is space at the top. Sir, what do you have to say about philanthropy from the topmost physicians or surgeons of India?
Okay, so philanthropy, I mean, is a word. It's not a great word because it makes you think you're doing a great favor and you're doing something for which you need a lot of respect. But it should be a fundamental part of every doctor. If somebody has become a doctor, it is at the cost of many human beings. We have all done our mistakes. we have seen that society needs a lot of service which the government cannot provide. So it should be, and if you are a doctor, you're different from an engineer, you're different from a business person, because you have an empathy in your heart, and that's why you have emotions in your heart, and you have a strong emotion to serve people and make a difference in the society, especially in terms of their healthcare and emotional needs. So it is very important to get that satisfaction. One should give back to the society. And one of the big ways a doctor can give back to the society is to go and see what he can do at a rural level, how he can help patients, how he can actually, you may not do procedures, we may actually diagnose patients with disease. You can give them a good health advice and prevent a lot of disease. You can actually make sure that some patients who require treatment and they are from underprivileged societies, they can actually go and reach the right place where they can get a free treatment. So all these things are very important. In whatever way you do, one must do as a doctor. It gives him an immense pleasure and fulfillment of being a doctor. So that is why you are considered as one of the God-gifted profession and one of the adorable person in the society, because not only that you have the highest skills, not only that you have a healing power and a teaching attitude, but also that you give back to the society and do it very selflessly. So part of your practice, I would say once a month, say one day in 3 months or one day a week, whatever you want, one should go and do this selfless service. In any way you want, you should help the patient. So it may not be you go to the villages, you can do many ways you can help the patient. If you have a nursing home, say if you can treat, say 1 or 2 or 5 patients free of cost or help them, it makes a lot of difference in your own peace and in terms of the satisfaction of what you did.
Sir, another question I have to ask you about your live surgeries. You do live demonstration surgeries not just in India but also abroad. They get telecasted all over the world. So there are 2 questions I have. What is your psychological thinking behind doing this? How do you prepare yourself? And also, what are the ethical considerations of such a surgery for the patient?
Okay. So that's good. And sometimes it's controversial also. If you ask me, in terms of like in your specialty in surgical training and in our specialty in interventional training, one of the quickest and the best way to teach somebody is to demonstrate a thing, say a new technique, or do it in live so that every possible complication, thought process comes, is discussed while we are doing it. And if suppose there are 5 people watching you to do while you are doing a surgery, only 5 of them learn. If suppose 5,000 are seeing it all across the world, so what happens is they all learn with you as one mentor. They all learn the basic steps, the complications, and the thought process. So it's a great way to train yourself and refine yourself for the people who are attending it. Now, the fact is, while we are doing it, so you have a set of chairpersons and mentors or specialists who would be asking you questions, and also from the crowd. Now, what happens is many a times you don't think about those situations or those questions. When you ask and you discuss, you may even get better ideas to do a better job. Somebody out there in the faculty or as a chairperson may actually have done a better case than you in this situation. The patient may actually benefit with the suggestions live at that place. So it's a two-way advantage. But the only disadvantage is what people think is that while you are doing it, you may be a little careless. If the patient gets serious, the treatment actually may suffer. So that is a disadvantage, but actually that is you can avoid it. So what we do while we are doing live surgeries, we don't take very complicated patients. We always have the backups. It is always done in terms of ethics by the patient's consent, written consent. We never ever, disclose or display the name of the patient or the face of the patient to maintain that privacy. And many a times the patient would actually prefer that you do it as a live case because you have many experts who are in the theater and who are in the panel to actually get the best. Many times we tell the patient, we are doing this, we'll keep it for the life case so that we have better interaction and do a better thing. If ever our patient gets into a problem, it happens all over the world. 1 out of 100 or 200 patients may get into a problem and start crashing. We don't do light then. We cut it. And in fact, 2 light surgeries go from 2 centers simultaneously. So the whole thing is shifted to the other lab or other center, and then you are at peace to actually manage the complication, and then we record and show it later on. In terms of ethics, yes, in some countries and sometimes in the country also there have been PIL saying that it is unsafe for the patient, but actually all over the world it's done with patients' consent. I have not only done live cases from here for different centers in India and abroad. I've also gone abroad and done cases in their meetings.
Right.
So it is an accepted way of teaching and new techniques all over the world.
Sir, this question comes from a young intern. He told me to ask you, where should he read ECG from?
So there are different textbooks, standard textbooks, but if an intern has to learn ECG, I would say the best way to learn ECG is from very simple books like Harrison, Davidson. These are the books which will give you, or even Hutchison, I would say, the basics of ECG.
Right.
If you really want to learn it fast, there are so many, tutorials on the Facebook and in the social media, which will actually give you tutorials where you can master basic ECGs in an hour or so. Not only that you master in terms of theory, they also give you a lot of, case examples and, worksheets where you can do and learn and master the basic ECGs. I would say, one of the best books, intern, of course, is it's an early stage. But for an MD level person or anybody above intern, one of the best books is Harrison or Davidson or Hutchison. These are books which are like Gita and Bible of medicine.
Right. Sir, what do you have to say about doctors on social media? Is it important? Is it not important?
See, at our time, it wasn't important. It was, in a way, considered unethical to advertise yourself. In today's time, it is the need and it is essential.
Okay.
Why? Because, one, there is a lot of competition. People should know what you are good at. Of course, the social media and your postings have to be ethical and correct. Second, you have a mass reach. Instead of, getting into a wrong practice, and which very few people do in terms of, unethical practice, there is a very good way to directly reach out to people, patients and doctor community to showcase what you do, to actually make them learn about new diseases and to make your presence felt. Anybody today also, it's like going to a restaurant. If I have a disease, I would actually look for that disease manifestations or whatever, and then try to look for an expert. If you are not there on a social media, then you are almost extinct. The only way people can reach you or know about you is through a patient who has been treated by you or through somebody who knows you. And it's the chances of that patient reaching to you is very limited. So social media is an essential tool. It should be done ethically and doctors should do it. I would not say it's a marketing activity. It is an activity to make your presence in today's world. It's a very practical thing.
So if you were not a doctor, then what would you have been?
If I was not a doctor, I was always wanted to be a fighter pilot, but because I had my eye issues with myopia, so the second thing I wanted to be is a doctor.
Right.
Then again, I wanted to be a cardiac surgeon always, but again, because of my, because I was myopic, I thought it's better to be a cardiologist. And then interventional cardiology was coming in at that time. And today I'm very happy that I took the right decision, because being a cardiac surgeon of that time and being an interventional cardiologist today, probably I can do much more in terms of intervention with a cardiac surgeon.
Right. So Thank you so much for all the insights. I'm sure everybody learned something from this.
I hope so. And it was very nice talking to you. And also, I find that it is a wonderful, I would say, entrepreneurship or a project which you have taken to actually kindle and ignite the young doctors. I don't think any other channel actually or podcast actually is focused to young doctors. And if they can benefit from this, I think that will be wonderful. I'm sure many minds would be ignited and kindled with this.
Yes. And of course, sir, during the podcast, you also agreed for the observership. I think that would benefit a lot of our audience.
They are most welcome, and all of us, would be very keen to interact with them and teach them and tell them whatever we know and what we are doing, so that these are the future doctors of tomorrow. These are the guys who would treat us in future. So we have to train them well.
Yes.
In every specialty.
Thank you, sir. That was a great interview. Thank you guys for watching. Please like, share, subscribe, send it to your family, your friends, everyone. And those of you who are interested in learning from sir directly through observerships, whether it's research or cardiology or just the way how he treats his patients, then please comment and send us emails, and we'll see that you get this 2 weeks with him. Thank you.